event. I'm going to start off with a few of the characteristics behind active shooter events. As you can see here, my name is Christopher Sunny. I'm the Assistant Director of Healthcare Emergency Management at HSS. I'm also joined by my esteemed colleague, Rich Boyer, that'll be speaking second here. He is the Assistant Director of Operations in our Security Division. Here we just have a brief overview of what we are going to be talking about today. We're going to like to start off talking about some of the shooting statistics. There is a large misnomer in the healthcare community and sometimes at large in regards to which hospitals are really most involved and affected by these types of incidences. So we want to put some hard numbers behind it. And then again, my colleague will be taking you through the discussion of what is an active shooter versus hostage events, going over some of the characteristics of shooters, looking at some real-world events, motivators, tactics, possible indicators, and then talking about our active shooter response. I'm going to be joining all of us again at the end and talking about some of the best practices that we've seen, identified, and worked with when developing active shooter programs for all of you to go back to take to your institutions and respective organizations. And then, as Danielle said, we'll be having a Q&A session at the end as well. So looking at from 2006 to 2013, there has been a total of 253 shootings and weapon discharges within hospitals. We're not talking about offices, schools, shopping malls, movie theaters. Believe it or not, we are only looking at hospital-based and healthcare events. There's been a total of 177 deaths, 128 injuries, and frankly, there's been very few states that have been spared from being involved in these types of incidences. The other big thing to look at is that hospitals of all sizes, from 25 up to the large metropolitan medical centers, 900 plus beds, are affected by these incidences. Going and taking a look at that information that we're talking about, you can see that there's been a pretty dramatic increase from about 2008 to 2010 in terms of a large jump in the average yearly number of shootings events. For the past few years, we've kind of seen a plateau in the number of incidences within hospitals, but unfortunately 2014 is really going to be looking to change that. In a couple slides, we'll be talking about some specific numbers, but we've had quite a few incidences very early on in the year in which we generally start to see these incidences occurring a bit later on. So it's pretty evident that these events are more prevalent within hospitals and the healthcare community, so it's very important and prudent that we prepare accordingly. Now, this is an important slide that we'd like to share. It really talks about the hospital size and the number of incidences. There is a general misconception amongst many within the healthcare community. We were at a conference just a couple weeks ago where someone was talking about the same piece, where we really think that these shooting events, these discharges of weapons, are primarily occurring within large metropolitan medical centers in the inner city, maybe some not well-to-do areas. And that's actually really not the facts. When you look at the total number of incidences, those hospitals with approximately just over 100 beds to about 250, 300 beds are really suffering from the vast majority of these events. Now, there's many reasons for that to happen, but generally, many times these are going to be our community-based hospitals, some of the smaller institutions. Some of the things that we look at from a security perspective is that you may not have that same physical security presence as you do at a community hospital as opposed to a major metropolitan medical center or teaching institution that may have their own security, police department, metal detectors, again, that actual security presence. At the facility that I came from on the northwest side of Chicago, like I'm sure many of you that are joining us today, we really try to push that notion that healthcare in our hospital is an open, caring, healing environment. And we want family members and visitors and friends to be able to easily come into and out of our facilities. We want to give that warm feeling. And unfortunately, there has to be a line in which we want to continue to provide an open environment, but also an environment that is safe for our staff members, our patients, and our visitors. So the next slide that we're going to be looking at here is going to be kind of a regional breakdown of shooting events. Again, that same statistics from 2006 to 2013 across the region. For those of you that are joining us in the Rocky Mountain area, we're looking at a total of 19 events. Predominantly, we see more of these occurring in the southeast and also the Midwest. But again, the point to take home is that there's no real part of the country that is left spared from these types of incidences. And there's some additional statistics that we're bringing in here. And before I get started, I really want to provide some thanks to one of our HSS program managers at Cheyenne Regional Medical Center, Tom Ahmed. He does a great job of tracking a lot of these statistics for us, getting them to us in a real-time manner, so we've been able to present them all to you. And we've updated our numbers as of last week. There was actually a shooting in a hospital, just outside of a hospital in Tulsa, Oklahoma, by some security staff members, which brings the total number of incidences to this year at 17. As you can see a very broad representation of states from all across the country, the East Coast, the Midwest, the Rockies, and there's been unfortunately a total of 10 fatalities this year alone. Now the numbers and the statistics that you've seen from our graphs, we'll be happy to share that with you if you want to connect with us after the fact. We'll have our contact information up at the end. But again, we have our great colleague, Tom Ahmed, who pulls a lot of this information together for us at HSS. We've also utilized a great study for those of you that want a good academic study behind hospital-based active shootings. There was one done back in 2012 and it was published in the Annals of Emergency Medicine. If you like that info, we can provide that to you as well. But it really gives a good facts-based evidence study on hospital shooting events, talking about the different types of facilities that are more effective than others, and again, happy to share that with you. Now at this time, what I'd like to do is turn the slide deck over to my esteemed colleague, Rich Boyer. Rich is going to start talking to you about some of our training statistics, our motivators, our tactics, and also our responses.
Thank you, Chris. Appreciate that. Welcome to everyone. Appreciate you joining during the busy lunchtime hour. I just want to make sure I got the slide deck working here. And it looks like we're good. So as Chris started off mentioning, obviously with this increase in active shooter events that we're seeing, not just in healthcare but nationwide, there's been a paradigm shift in training and response, and that's one of our main purposes here, is to help you understand that we've got to increase the awareness of our staff members so that we can improve our response, thereby helping protect our patients, our visitors, our staff, and our physicians. Some of these statistics down below are just amazing to me. The first one, obviously, there are those folks that have no training but have developed that survivor mindset, and 10% of those people will be able to respond to an active shooter event even without the training. On the opposite end of that spectrum, however, is kind of a frightening number. 10% of us that have received this kind of training will not be able to respond. But of the amazing statistic on this sheet is that 80% of us we can be trained to respond, and we can respond better. And if we are trained, we will not only respond better, but we'll be able to recover better from an active shooter event. In the law enforcement military community, we live by a saying that you'll do in stress as you do in practice, and that is why it's important that we train for these events so that we can respond better. In looking at active shooter, the first thing we have to do is understand that there's a difference between active shooter and a hostage situation. And the key behind active shooter is that this is when somebody is actively engaged in killing someone. They typically are in a populated area. Typically we're seeing with firearms, but the most important part is they tend to be able to have free movement or unrestricted access into the facility where they're at, as opposed to a hostage situation where this is where they're holding somebody against their will. They have demands. They're not actively engaged in killing someone. And the unique difference is that in an active shooter situation, in response, we have to stop the action. Whereas a hostage situation, we want to negotiate for the safe release. Two different activities, two different responses. Looking at the numbers in the active shooter, typically what we see is 98% are a male shooter. They usually have multiple firearms, which is what we almost always see. In some cases, we are seeing the improvised explosive devices. We saw that all the way back to 1999 here at Columbine in Littleton, Colorado. These events are not lasting very long at all. Typically, the average is they're only lasting about 8 minutes. And the startling thing is that's typically before law enforcement has a chance to respond. And as it states, 63% of these are ending prior to police arrival. Whether it be the shooter is committing suicide, they're subdued by the survival mindset of taking out the shooter, or at the completion of what they came to achieve, they're leaving the premises. Usually they're occurring during the daylight hours, populated areas, and the reason for that is to maximize a higher body count. That's what their purpose is, and they will usually go after a targeted person or persons. But if they're unable to find that person, they will go after the random victim along the way, which is why we have to find a way to harden our targets and create these resistive passes, because they will go by the path of least resistance to be able to get their maximum body count that they're after. Looking at some of the root causes of why this is happening, first and foremost, what we have to look at is the workplace is the reflection of our community, and economy, no doubt, plays a part in this. With unemployment rates constantly increasing, we're seeing that more and more companies are downsizing their workforce. And this is leaving people without jobs and financially destitute, therefore fueling some of the animosities towards a business or a particular group. Obviously, whether it's our patient population or our staff, we are seeing an increase in domestic violence situations into our facilities that also tend to impact us. Drugs and alcohol, that chemical dependency piece, we're seeing more and more of that, especially in our own state as we start working through some of the new legislation with legal marijuana. Are we going to see more of it? We'll have to see as it goes on. Obviously, behavioral health has been a huge thing. Having been in healthcare in the Denver metro area since the 80s, where it seemed like we all had a inpatient behavioral health unit, we're seeing more and more of these units closing and less behavioral health beds available, which is creating more of an outpatient approach to behavioral health. Therefore, what we're having is more and more patients walking in off the street, some of which we may have a history with, some of which we may not, but definitely a difference in the type of treatment that we've been seeing throughout the many years. Looking at the characteristics of various types of active shooter situations, we've broken down 4 of them here for you, but we'll start off with the disgruntled individual. And, you know, we can look at the 2012 incident at the ICE office out in Long Beach, California, where the agent shot his supervisor. Or we can look towards Johns Hopkins, more closer to home because this was a medical center. In 2010, this is where the son of a patient was speaking with the doctor, and as the doctor was giving the patient's condition, the son lashed out, shot the physician, killed his mother, and then killed himself. Clearly, they're disgruntled. They're being fueled by their rage or their anger towards a person or an organization. They're carrying it out. Then we have the revenge seeker. We saw this with Columbine back in 1999. You know, in that one, we talk about the weapons. Both of these shooter suspects had multiple weapons. They also had placed about 99 improvised explosive devices throughout the school. We saw this just as recently last week with the University of Santa Barbara shooting. Clearly, you know, a manifest was released that had intended victims on it, and they're looking at how old was this manifest. It could have been upwards of a year old, just like what we saw with Columbine, where they had the actual hit list out. Then we have the self-motivated terrorist. We saw this down at Fort Hood in 2009, and of course we all know that we just had another shooting there this year again at Fort Hood. We had the Sikh Temple, Oak Creek Sikh Temple, where the lone gunman, this is the self-motivated person, was able to kill 6, a police officer wounded, and eventually ended with the shooter being killed. Planned assault, we're seeing this more and more. We can go all the way back to '99. We can look at Virginia Tech, where it was clearly planned out. Here closer to home, we saw this with the Aurora Theater shooting, where the person was able to make internet orders of munitions and body armor, was able to booby trap an apartment. Same thing we saw again with UC California at Santa Barbara, where a lot of planning into this, where maybe we should have seen some red flags, and moving forward, hopefully we become more understanding of some of these motivators and red flags that we can look for. Obviously, some of the motives and tactics are the intended victims. What is the type of person they're going for? Is it a disgruntled employee going after their boss? Is it a loved one of a patient who feels that the care given to their loved one wasn't enough? But they're definitely going after that intended victim to correct what they perceive as being a wrong to them or to their family member. Obviously, it's being precipitated with that frustration and rage. We're seeing more and more now where they're getting the body armor. It's available on the internet at little or no cost, and we've been seeing it increasing for years. We look at Aurora Theater, where he was decked out in what essentially looks like SWAT gear. Clearly, with these shooters, their desire to kill overcomes their personal safety. I believe they know going into it that it's not going to end well for them. So with this frustration and rage, how many other people can they take out in the process? Because ultimately, they're going to continue to kill until they're stopped typically, and that's the scary part about it, and that's why we have to do our part to have a better response and a better way of hardening the target and making it more difficult for them to maximize that higher body count. One of the things when we look at the prevention or mitigation of active shooter situations is we have to look at it as a big puzzle, and we have to try and find the pieces that we can put together. And we've seen this time and time again with active shooter situations. I think of Virginia Tech, where a lot of different people had pieces of that puzzle, and it looks like we're seeing the same thing now with UC Santa Barbara. It's just nobody put the pieces together of that puzzle to realize we have a volatile situation developed here. So we have to become empowered to look at different key indicators with our people around us, whether they're the visitors, whether they're the patients, or whether they're fellow coworkers, and start putting these pieces together. And I'll pretext this by saying that not any one of these by themselves are a clear indicator that somebody's going to be an active shooter. And even with a couple of the combination, perhaps it's not. But as we start to see the patterns develop and these pieces come together, that's when we have to start realizing that we might have a problem, and we need to feel empowered to go to our supervisors or other individuals in the community, whether it be law enforcement, and report these incidences to try and prevent the tragedy from happening. Some of these can be an increase in absenteeism. If you've got that coworker or that employee that has always traditionally had a pretty good attendance record, and suddenly their absenteeism increases. It's something that you might look at. There usually is an indicator as to why. Are they displaying signs of depression or some type of withdrawal that, they were an outgoing person and now they're more introverted and keep to themselves? Do they have those mood swings? Is there any type of noticeable increase in maybe alcohol or some type of illicit substance like drugs that you can notice, and by itself may not have been an indicator, but now you're tying that it seems like they're using alcohol more, they're introverted, they're no longer that extrovert that they've been, and they're suddenly missing work. Some other things is, do they have an increased temper at work, anger management issues? It's people that I like to call or refer to as energy vampires, where they can just suck the life out of a room. Maybe you have meetings and they're very negative about the company or a policy, or very negative about their boss, and maybe that's a change in their behavior that we should notice. Are they talking about personal problems, things that are going on in their personal life at home, whether they're domestic issues or not, that we need to take notice to? Are they somebody that has an increase in their interest in violence or firearms? I've carried a firearm for 30-some years in one capacity or another, but people at work know that if they see me on a website, I'm suddenly looking at guns, there might be an indicator, because I don't walk around with pictures of my arsenal on my phone and I'm not showing them off to people. And these are indicators that we've seen to where suddenly on social not be anything. They may be an avid hunter. But together with these other indicators, we can piece them together. And then finally, is there some type of behavioral health history that we need to acknowledge and look for that may be an indicator with these other signs? I mentioned it a couple times already, but one of the principles that we need to do in order to help mitigate these or prevent a worse event is we need to harden the target. And while this is not the proper venue for a principle we call CEPTID, or crime prevention through environmental design, nor do we have the time to go into it, I thought I'd just cover a few areas that we, the individual employee in our healthcare settings, can do to help this, to harden the target. And we've got to look at a layered approach, kind of like the layers of the skin of an onion. And as we add these layers, we make it more and more difficult for the shooter to move freely, and now we're able to restrict that access into areas and therefore help keep the situation more contained. Obviously, a lot of it starts with our access control, and working in healthcare in Colorado and various states throughout the nation, we do pretty well at this. But as Chris mentioned, you know, we're a 24-hour environment. We want to facilitate that healing, therapeutic treatment method, and so our doors are always open. And so we have to find a way to control our access a little bit more. And while they come into our waiting rooms and our ERs, are we hardening that target back in the treatment area? Do we have visitor control processes in place? Are we giving them some type of visitor badge to where we know at any given time that we have somebody up on the 5th floor of a mom-baby unit? Are we doing something different after hours? Are we restricting access to a single designated access control point? Or do we leave our main entrance and the emergency entrance open? And if we are leaving them open, are we staffing them with somebody that can see someone coming in? Apologize for that. I don't know how my slide moved. And then also from access control, are we practicing restricted access? Are we doing some lockdown drills? And what are our processes? Are we an antiquated facility where we're still using lock and key, and theoretically it would take our engineering or security personnel 45 minutes to lock the facility down? Or do we have that new advanced technology, something through a computer or a door plunger, where we can push that button and lock that area or that building down instantaneously? Another layer would be our video surveillance, and quite often there's a misnomer here that if we have cameras up, somebody's watching them, and that's not always the case. Oftentimes our video surveillance systems are very reactive. But there are those cameras in many of our hospitals where hopefully we have some security personnel watching them, especially the high-risk areas or the entrance points. How long do we have video monitoring for? You know, we pass out a lot of alerts in healthcare from one facility to another of a suspicious subject that might have went to facility A today, and lo and behold, we've seen them at B on the cameras later. Obviously, when we get into patient care areas, we have to be a little bit more careful with the privacy concerns, but more often than not, our entryways, we do a really good job at putting video surveillance up. Now, what are we doing with it? The next layer would be our duress or our panic alarms. Do we have them installed, and where are they? Most importantly, who's monitoring them, and how quickly can they respond once the duress button is pushed? And I think that's where training and response are key. You know, if security is going around testing the duress buttons once a month, that's great, but I would always advocate that security person testing the button have the employee, the staff member, push the button themselves, which will serve two purposes. One, it will show that that employee is competent in knowing where the duress button is, and two, how to depress it. And the second point of that is quite often they'll come across as a text message or an alert over a security radio. That'll build the confidence level of that employee that once they push the button, they can hear how immediate the radio call was to know that, wow, I do push it and somebody is coming. Some of the other systems we look at are emergency communication devices, these mass notifications. You know, college campuses across the nation have been doing this quite well, and we've got some larger medical centers here in Denver that do it well as well. But when we have that emergency, how are we getting the staff throughout the campus to know that, hey, we have a campus-wide event going on? Or are we sharing an environment in our community with other medical campuses? And I think of many hospitals in the core downtown Denver area that right across the street is another hospital. And are we sharing that information to where if Hospital A has the event, undoubtedly it's going to affect Hospital B across the street? What are we doing to share that communication with them and have a mass notification process in place? One thing we have to do, and I know most facilities I'm involved with, come up with an active shooter policy. And it's important that we do that and understand that we have to have a policy, and I don't want to steal any Chris's thunder later, but then we've got to train to what's in our policy for a better response and better preparation and mitigation. But we have to understand that there's a huge difference in how we want our staff to respond to an active shooter situation versus, say, maybe a code pink, where active shooter, we want to make the facility appear desolate. We want to appear where nobody's in a hall, as opposed to code pink or some type of infant abduction. For those of you outside the Metro Denver area that may not know that term, during an infant abduction, we want to saturate the halls. We want as many staff members out there as possible to create that gauntlet effect for the abductor to have to walk through. So we've got two different, completely different responses here that we have to delineate and train for. Do we train our employees to feel empowered? You know, in emergency management, we have a simple saying, when in doubt, call it out. We have to help our employees understand that if they hear something that sounds like a gunshot, it is far easier to de-escalate a situation once we've determined that it's not a threat than it is to try and escalate in the middle of an event. But we've got to make them feel empowered to do so. Are we exercising? Have we done a training drill, whether we started off with some training like this where we're all in a classroom and we're learning the basics of active shooter survival, to we've done a tabletop and now we're having a full live exercise event with our community. And then finally, what have we done for those off-campus areas? And having run a pretty large medical facility in the metro area where we had 15 community-based areas, the response in that small dock in the box in the community 2 neighborhoods over is going to be completely different. You know, their only response is going to be 911 and maybe evacuating or getting out. But they don't have that security team there to help cordon off the area. So we have to make sure that we include all of those ancillary off-campus areas, because that's going to be key if the event happens off-campus and not our main campuses. We've heard for years, and obviously the Department of Homeland Security came out with the run, hide, fight scenario, and that's what we've all geared towards, and I think that's important. And we're going to go through each of these stages independently here. But obviously, option number 1, we've got to try and evacuate the situation if at all possible. But if we can, option 2 is to shelter in place and hide out, with finally option 3 being taking out the shooter in some way, shape, or form. The first thing we have to do, however, is develop that positive mental attitude, what I call that survivor-protector mentality. You know, if I were working in an office building, clearly I may only have that survivor mentality, but we're in a healthcare setting where we have patients who cannot just get up and run, hide, or fight, and so we have to become protectors as well. So what we have to do is we have to first accept what we're seeing and hearing. You know, we have to understand and acknowledge what's going on. We have to assess that situation and accept it. We have to realize that we can't approach that area. That is a fatal area not to go into, and that's really hard in the healthcare community. For someone like myself that comes from military or law enforcement, it's not so difficult for me, but for our clinical staff whose sole purpose is to care for that patient, that's a lot harder thing to help them understand. But what we have to help them understand is if they're not able to respond and help after the event, what good are they? Number one, we have to remain calm. Fear is contagious, and we can't let it control us. It is contagious, so we have to remain in control of our fear so that we can help others. We can't go into that helplessness feeling. I mentioned it already. If you think you hear the gunshots, call it out, because oftentimes a gunshot in person, especially indoors, will not sound like it does on our television or if we're at the range. We need to make that decision, and most importantly there, we have to commit to the decision we're making. If our decision was to get out, that's what we've got to do. We've got to evacuate the area. But if our decision is we can't get out, now we've got the shelter in place, and we need to try and get as many people hidden away in locked rooms and safe zones, as we call them, as we can. But either way, we have to commit. Obviously, we talked about get out. And this is where I like to tell everyone to play the what-if game. You know, all of us at times, regardless of what our job in healthcare is, we're going to have those moments of downtime to where we can think about it. And I like to play the what-if or the scenario game. And if I'm sitting here at my post or my workstation and somebody comes through the door with a firearm, what am I going to do? Where are my exit points, my routes of egress? Where's my nearest safe room? If we plan that out in advance, like I said in the very beginning, we'll do in stress as we do in practice. We got to leave everything behind. We tend to be inclined to want to grab our personal things to go with us, but the idea is that's taking up valuable seconds. And with these situations being over within minutes, and typically before law enforcement arrives, seconds are valuable, and we can't waste them by grabbing things. We need to encourage people as we're either evacuating and getting out or we're going to hide out somewhere. We can't wait for people because ultimately we've got to figure out what motivates us to go home every night. But what we should do is try and encourage others, or what I call call out. Make sure everyone understands what the situation is. Encourage them to come along with us. I always tell people that during a situation like this, if they see a vapor trail going by them, that's me. Come follow me. One thing we don't want to do, we don't want to activate fire alarms, and we don't want to activate the code blue teams. You know, on a fire alarm, once we pull that, we're trained to get out of our areas, but the plan of egress may be a little bit different. So if we activate a fire alarm, people are going to come out of their work areas who may already be in a more secure area, and it may place them into that fatal funnel. Likewise, it's quite possible we're going to need our medical resuscitation teams at the conclusion of this event. And if we call a code blue right in the middle of this event and they respond, we have now placed them in harm's way. So we don't want to pull these fire alarms or activate these emergency processes and get people into that fatal funnel area at all. One thing that's hard for clinical staff is we don't have time to stop and care for wounded at this point. Again, it comes down to we have to determine what motivates us. And, you know, I always say it this way. I've got wives and children, some ex-wives, and children, and alimony and child support and college funds. And I know what I have to go home for every day. And that's what we have to do. And so ultimately I'm better if I can help people after the event than if I stop to try to help someone along the way and I become a victim myself. And of course, we want to warn people while we're evacuating, try and get as many out or hidden as we can to help make them safe. But of course, if getting out is not an option, we need to hide out. And by hiding out, there's a key out here that we need to keep out the perpetrator. So we need to go behind locked doors, and the time to identify these areas is hopefully not during the event. Hopefully we've looked at our work areas and we've identified what rooms we can go to, whether that's a soiled utility room or maybe a medication room or a locking office or a conference room that doesn't have a classroom lock on it. We need to go somewhere where we can hopefully lock the doors. We want the area to appear as if it's unoccupied. So we need to lower the blinds, turn off the lights, silence our cell phones, and make sure we keep them darkened, because if it lights up the room, that may attract the attention of the shooter, who is, of course, trying the path of least resistance and looking for that maximum body count. sometimes we'll get into a room that we can't barricade, especially if it's a conference room setting. Or I think of a lot of times in hospitals we have the double doors, the double egress out of or into an intensive care unit. There are other ways we can barricade that door to make a path that is not easily passable, like putting a bed up against a door. You know, when we're in that survivor protector mentality, you know, we may not be able to get that patient out, but can we barricade them in their room and get them seated in a chair inside a locking bathroom, but have that bed pushed up against that door in that patient room to help barricade it and keep people out. Once we're in the room, we want to spread out. We don't want to huddle together. Huddling together creates, unfortunately, a very simple target for somebody that's going to come through the room and, as we say, spray the room. If we're spread out, we have a better chance, especially if we have to go to option 3 and take out, of being able to attack from different areas as opposed to one group all being huddled together. And obviously we have to stay completely quiet. Again, we want the room to appear as if it's vacant and nobody's in there. As we start preparing the team, it's important to understand, and this has been a theory of mine throughout my entire life, leadership knows no rank. And some of the best leaders I've ever knew never had any stripes on their sleeves or bars on their collars or titles after their name. Whomever it is that takes control and can stay calm, that's the key to this. And so that's the key behind preparing, because remember, 80% of us can train for this and we can respond better. But as we're preparing our team, we need to decide who is who and what our roles are, because there are going to be those among us who maybe we can get into that room and to hide out and to keep out that shooter, but maybe they're not a good person to help us take out the shooter if that comes. And as the leader of that group, that's what we've got to determine. Or we've got to determine who's going high. If that shooter comes through, who's going for the legs and who's going for the hands, and who's going to go for the back of that shooter so we can take them down and overcome them. Obviously, as we're leading people to survival, we have to, again, remember that fear is contagious and we have to stay calm. Somebody's got to be in control, because fear breeds fear. And so we have to stay in control. We have to take control of the room. We've got to make sure that we're constantly acknowledging what's going on, assessing it and accepting it so that we can remain in control, remain calm, and not show fear. Obviously, we have to know that we can do this. Simply stated, in a high-stress situation, we will survive. That's the kind of survivor-protector mentality that we have to have. Finally, and it truly is just a final option, if we can't get out and we can't hide out, we may end up having to take out. And obviously, we've seen the examples of whether it was United Flight 93 or even a little closer to home. We saw this with Deer Creek Middle School a few years ago, where the math teacher was able to subdue the shooter without a death involved. We had one student shot there, but because a math teacher took quick action and was able to subdue the shooter, further victims were prevented. I will tell you, having been in this situation myself, it is a decision that is really hard to make. Again, it comes back to, once you make it, you're going to have to commit to it. And it should only be a life or death, last resort situation. When we make that determination, though, we've got to figure out what we're going to do. How are we going to create a distraction for the shooter if they enter the room, screaming, yelling, throwing things at them? It's what we learned a long time ago in the military and law enforcement with our flashbangs, our distraction devices. We want to be able to pull their split-second attention away so that we can gain control of them. We've got to start looking around in our work areas to determine, if that happens, what do we have? One of my favorite is obviously a fire extinguisher. It's big, it's heavy, it can spray up to 25 or 30 feet if I need to. But it can also be used very defensively if need be. But we need to look at those items around in our work areas, in our break rooms, in those rooms where we're going to hide, and see what we can use to our advantage. Obviously, I've said it way too many times, but we've got to commit to the action. And obviously, we have to disrupt so that we can subdue or incapacitate that shooter and survive. Let's talk a little bit about police response, because I think this is important. Oftentimes in healthcare, this is something we don't think about. And I know at my facility, when we started preparing for active shooter, this was a huge disconnect area that we had to look at, because we had completely different missions. Our clinical folks, they were the healing therapeutic lifesavers, whereas law enforcement, they had one purpose and one purpose only, and that was to neutralize the situation. And clearly we saw a disconnect, and law enforcement had a hard time understanding why a clinical staff member may be willing to put their own life at stake and stay behind with their patients, whereas the clinical staff member sometimes just could not understand why a police officer would stack up in a hallway and walk over the dying and the wounded and continue down the corridor without rendering any aid. And the key behind that is we just have to acknowledge we have two different missions, and their mission is to stop that action and neutralize that threat. Some of the things we have to expect when police come is, number one, they're going to go to where the incident is happening. Typically, a lot of our security teams, at least in the metro area, have set up access control badges specifically for law enforcement so that they can get into those high-risk areas that maybe you got to have a badge to get into. They're not going to stop and help the wounded or administer aid. They're just going to keep stepping over people as they move down the hall, because they don't really know who the threat is, and they have to consider everybody as a threat. Some of these responding law enforcement officers may be in full SWAT gear with assault rifles and tactical vests and helmets. Some may be in their patrol clothing or bicycle patrol clothing, and then again some may be plainclothes detectives that are coming. And we have to understand that there may be a variety, because typically in an active shooter situation it's going to be that beat or that patrol officer that's responding, whereas typically in a hostage situation we may see that SWAT team have time to stack up. Obviously, we talked about the weapons. Some will have their handgun, some will have a shotgun or a long rifle. And then, of course, we may see the assault rifle. More and more police officers carry assault rifles. And if you've never been in a situation to have a weapon pointed at you, it's very scary, very intimidating. I can tell you, having carried a gun since I was 17, I'm scared to death of being on the wrong end of one, regardless of who's got the other end of it. I mentioned it. Anyone can be a suspect to them. They're going to be shouting commands. Typically, it's going to involve telling you to let them see their hands and to get on the ground. Some of it that I can tell you is just drop whatever is in your hands and raise your hands, because police officers are taught first and foremost that hands kill. And so whatever is in your hands, even if it's a soda can, drop it and raise your hand, show them your palm, spread your fingers. Get on the ground. They're going to give you very clear, explicit instructions, and I would recommend you follow those. Don't make any quick movements towards them, because anything that you do, you don't want to be interpreted as a threat, and that's what we would call closing distance in law enforcement. So don't make the quick movements. Just do what they tell you to do, show your hands, and get on the ground, and we've got to train staff to do that. They may be asking questions, and when they ask, give them clear, concise answers as to what the shooter looks like, how many of them are there, which way did they go, so that they can respond. Ultimately, as we look at training, and of course you've had a very quick overview of our normal active shooter program, but hopefully you've seen that training is that important key component that we need in these healthcare facilities so that we can respond better when they happen. What we have to do is we have to start seeing these warning signs, just like we saw most recently last week with UC Santa Barbara, to where there were warning signs. Virginia Tech, there were warning signs. We have to start seeing them. We have to put these pieces of the puzzle together to try and prevent these completely from happening. But if they are happening, then what we have to do is we have to understand what the motivators and the tactics are involved, and so that we can respond better. Ultimately, so that we can have that response plan in place before it occurs, because in the end we have to survive. We have to develop that survivor-protector mindset and say to ourselves, in this high-stress situation, I will survive. At that point, I will turn everything over to my colleague Chris to finish up the rest of the PowerPoint.
Wonderful. Thank you much, Rich. Great presentation as always. I literally just wanted to take 1 or 2 minutes, so we do have time for questions and answers, to talk about what Rich touched on, is that capability building cycle. We don't just want to develop an active shooter response. We want to develop and instill a capability within our staff, within our clinicians, within our support staff, our leadership during one of these incidences. So for those of you that have been involved in emergency management at some point or another, to some degree or another, this is going to be old news, but really looking at all phases. Develop an active shooter plan. Make sure it goes through frontline staff and your leadership to make sure it's functional, applicable, and can really be utilized during a real-world event. Once you have a solid plan in place and it's approved by the appropriate stakeholders, looking at risk, looking at legal, looking at your incident command team, then train your staff. Make sure you train your hospital incident management team to what they are going to be doing in terms of their reaction to the event, and also your frontline staff. Going back to that run, hide, fight mentality, going over some of those major pieces and challenges that we have as clinicians with being able to escape if we may have an injured colleague or patient. Next, we're going to be looking at exercises, and I have a great exercise slide on the next page that kind of takes a look at the premise that we really need to crawl before we walk, before we run, to make sure everyone gets the maximum out of these types of events. And then lastly, whenever you do have a real-world event or an exercise, develop a corrective action plan. Do your after-action report. Make sure we identify what we did well that we can strengthen and build on for next time, and also identify what our areas of opportunities are so we can address them, remedy them before a real-world event happens. And one thing that I've challenged at my facility, Rich and I have been talking about this, he had a challenge at his facility, and we see across the country, is that a lot of times hospitals like to go into those full-scale exercises with their community partners, running through the institution and running and gunning. And while that's cool, for lack of a better term, it's really not going to be very functional, and your staff isn't going to get anything out of it rather than really being scared. So what we really want to stress is to make sure that you start on the low end with your seminars, your workshops, your tabletops, and then start to gradually build the complexity of your exercises in which you will also start to have an increased capability. So sit around once you develop your new plan. Have a tabletop exercise. Make sure we go throughout the pieces. Invite a community partner to sit around and talk about what their response is going to be. Make changes as needed. And then start to look at frontline staff training, leadership training at drill, very specific pieces of the plan. Start to look at functional exercises on single units throughout your facility. And then really after a year or two, that's when you can start to look at those full-scale exercises, having an actor, bringing in your community partners, and really putting all these wheels into motion. But it's important that we do it appropriately to make sure our staff get the most out of these events. As I said before, we have some contact information here for both Mr. Boyer and myself. If any of you would like any information on the statistics we shared with you today, you have our telephone number and our email address listed below. You can also follow us on Twitter, search HSS Security. We have our own Twitter. We have our social media team actually live tweeting this event today. But we'd be happy to provide you any resources or answer any additional questions that you may have. And with that, I want to thank CHA once again for their opportunity to work with them on this. I'll turn it over to Danielle for the question and answers.
Thank you, Chris and Rich. Excuse me. At this time, everyone, we would like to open the line or actually the webinar for you to answer questions. And because we have such a large audience, again, we're going to ask questions to the webinar toolbar. So if you want to go ahead and you can ask your question to the question section or the chat section, and then the questions will be read aloud, and Rich and or Chris will address each question. So at this time, go ahead and please ask your questions. Carolyn, yes, you can get a copy of the presentation. It is being recorded today, and I can definitely send you the PowerPoint and or the file is quite large when it comes to the recording. So I will include my contact information in the follow-up email after the webinar, and whoever is interested in the presentation itself can get a copy. We have another question here. And they ask, in the beginning, we're talking about hospital shootings. How do you define a hospital inside, outside, and on the grounds? Chris and Rich, are you still there?
I'm here. This is Rich. Chris, did you want to answer that?
I'm sorry, everyone. This is Chris. My mic got fouled up and disconnected here. I'm back. When the statistics that we were pulling and that we track and we aggregate, we're looking at a discharge of a weapon within a hospital campus. It isn't always only going to be a perpetrator or just a security officer or a police officer. We're looking at a combination of either an accidental or intentional discharge of a weapon on a hospital campus.
Okay, our next question is, have any community health centers had a functional exercise, or have they just done tabletop exercises?
I'm sorry, repeat the first part of the question again, Danielle.
Sure. She's asking if any community health centers have had functional exercises or have just tabletop exercises been done at this time.
You know, we've had the pleasure of working with organizations across the country, and it really depends on what level of preparedness or the program that you're at. We have had small community health centers, clinics, even private practices that have gone through the process of developing a plan, having a tabletop, going up to a functional exercise where we've had actors come in to play that role to really have staff kind of put into action what their response is going to be. So from our side, there is some great benefit to it, but we need to make sure that it is at the appropriate point in the planning and preparedness cycle.
Okay, our next question is, who do you think are the most critical hospital staff to receive active shooter training? Please describe the level of training you would recommend.
I'll pass that over to Rich.
Well, I would say clearly if we have a limited amount of people that can be trained, like many of the items we do in a hospital, obviously critical personnel, security sensitive areas, emergency departments, ICUs. In best world scenario, everyone should be receiving this training, and I worked at a hospital with several thousand employees. And so I think one way to do it is a lot of us have computer-based training requirements every year. And that's one thing I would encourage is developing some type of active shooter for that to at least get the basic knowledge out, just like we do bloodborne pathogens or code red or code peak response. Sitting down, having a formalized training where bodies are in chairs takes money. And so then maybe we're looking at something different. What we have traditionally tried to do, at least with HSS facilities, is let's get the managers, directors, and charges in there because they can go back and do some lunch and learns with their staff members and take back what they've learned from this. So to answer it, everyone should be getting some type of active shooter response training. And then as finances are affected, critical sensitive areas and then key leadership roles that can take the training back to their units would be appropriate as well.
Okay, our next question is, do you see hospitals moving toward more technology-based protective systems such as metal detectors to prevent an active shooter event?
Chris, you want me to take that one?
Yeah, go ahead, Rich.
Sure. I will say this, still in healthcare, and I think the statistic is still hovering around 6%, only about 6% of the hospitals across the country utilize metal detection. And it can sometimes create a false sense of security in that we can't put metal detectors at every single one of our entrances. And if you've got a large metropolitan medical center, you may have upwards of 30 to 50 doors that you cannot secure all day long during a business day. Yet if you have that metal detector at one door, unless you're funneling all your foot traffic through there, you're still vulnerable to other target points. In Denver, I can tell you, we tend to be a little bit more spoiled. We have more hospitals that have metal detection, but typically, again, they're only at the emergency department. So while we're protecting that security-sensitive area, how many other areas of the hospitals are still exposed? And so I don't know that the trend can increase as far as metal detection goes, only because we do have to maintain that healing, therapeutic, open environment, and becoming a TSA-like business where we are funneling all foot traffic through one entrance and we have these long lines just to get into outpatient care might not be good for our bottom dollar. I do see us augmenting security with more low voltage or electronic security means. There's no doubt about that. But I just don't know that we'll see a trend of increasing metal detection outside of emergency departments much.
Okay, that is the end. I do not have any other questions at this time. So if we want to give the last minute here, if anybody has any other questions, please feel free to do so. And then I think we will end on time. We have a couple more questions here, actually. Do you feel staff should be given tasers for protection?
I'll jump on that. I don't know that we want to introduce too many weapons into our controlled environments as it is. While the electronic control devices can be a very effective tool, and we have many security officers throughout our company that are trained with them, quite often, and there are some startling statistics, especially where firearms are concerned, where the weapon that was used was actually the staff member's weapon. And so introducing more weaponry, even if it's a less than lethal weapon like a stun gun or a taser, into the environment may not be in our best interest. I think living by the training of run, hide, or fight would be our better mentality, because quite often the average person is not going to be able to use that weaponry in the situation. Secondly, it is a less than lethal means of force, and it's the old theory of going to a gunfight with a knife. Unless they have a taser type of electronic control device that deploys the probes upwards of 20 feet out, they're going to have to get up close and personal with that person with the gun. And I just don't know too many people that are going to be able to do that and actively engage in a tasing.
All right, thank you. I want to thank Rich and Chris today. I have one after one here, and I don't have any other questions sitting in the queue at this time. So I want to thank Rich and Chris for this afternoon's presentation. Again, everybody, I want to remind everybody, be on the lookout for an email from me with contact information for Rich and Chris, and also my contact information if you are interested in getting a copy of this presentation. Again, thank you, and everybody have a great weekend.